So welcome back. I know this is a long chapter here, but let's talk about the Monobactams. Our drug here that we want to study is aztreonam, azistam. This is a synthetic beta-lactam antibiotic. It inhibits bacterial cell wall synthesis, and it's actually resistant to most of the beta-lactamases. The problem is it primarily, or actually, not primarily, it is only effective against gram-negative bacteria. So that's our Enterobacter, our E. coli, Klebsiella, Pseudomonas. It's used for the treatment of septicemia. It's parenteral only. You'll also see it used in lower respiratory infections, some of our pneumonias and bronchitis, skin structure infections, intra-abdominal infections, and gynecologic infections. If it is being used in any of our mixed infections, then it needs to be combined with another antibiotic because it is only gram-negative. So we need gram-positive coverage and anaerobic. It does not cover anaerobic bacteria. Adverse effects include frequent increases in the liver function test results, nausea, vomiting, rashes, and phlebitis. It is parenteral only. It may be safe for the use in patients who are allergic to the cephalosporins or the penicillins. Let's move on to our macrolides. These are erythromycin. So you notice these all end in myosin, right? Erythromycin, azithromycin, clarithromycin. So Z-Pak, you maybe have heard of the Z-Pak. So these are bacteriostatic, and they bind to the 50S subunit of the bacterial ribosome, and they inhibit the protein synthesis. These are actually pretty effective for certain infections. In high enough concentrations, they can be bactericidal, but the bacteriostatic will eventually die. So we use these for strep infections, particularly our group A beta hemolytic strep, mild to moderate upper respiratory and lower respiratory infections, our spirochetal infections like syphilis and Lyme disease. You notice gonorrhea, chlamydia, mycoplasma. So these are really effective for sexually transmitted diseases and community-acquired pneumonia. Our erythromycin activity is actually equivalent or parallels that of penicillin. So we'll often see the erythromycin used if a penicillin allergy exists. The azithromycin and clarithromycin are also approved for Mycobacterium avium intracellularly. This is a complex infection. It's an opportunistic infection that's associated with HIV and AIDS. Clarithromycin was recently approved for use in combination with omeprazole for the treatment of active ulcer disease when we have an H. pylori, Helicobacter pylori infection. The azithromycin is less effective than the erythromycin for strep and staph, but it's better for respiratory infections when we have H. influenzae, Moxilla, or Mycobacterium present. So when we look at these, it's not just a one-size-fits-all with the mycins. They do, however, share common adverse effects, GI effects. Primarily, you'll see more of these with the erythromycin. The Z-Pak, the azithromycin, and the clarithromycin, we'll see less of the adverse effects. They do have a longer duration of action, better efficacy, and better tissue penetration. So you can see why this Z-Pak is so handy, and so many people like it because it's 5 days of treatment, but the actual action, the duration of the action is 10 days for that medication. Then we have ketolide. Now ketolide, ketek, telithromycin is semi-synthetic antibacterial in this ketolide class. It's the only drug in its class. Chemically, telithromycin is designated as a type of erythromycin, but it's a chitolide and it differs from the macrolides, the group that we just studied, because it lacks a particular enzyme, not really an enzyme, but a chemical. It lacks a thing called L-cledinose at a position in that erythronolyte ring. And so it changes its function just a little bit. It changes its empirical formula, its molecular weight, and so as a result, it's the only one in its class. It does have better antibacterial, I sort of say antimicrobial, just out of habit, right? But it has better antibacterial coverage than the macrolides. However, it is associated with severe liver disease. It is contraindicated specifically in myasthenia gravis. And because of its hepatotoxicity, it can prolong the QT interval in the cardiac system. It can cause changes in visual disturbances, loss of consciousness, and C. diff. It actually is pretty limited. Its use is actually pretty limited because of that. It does interact with a lot of other drugs as well. Let's move on to the tetracyclines. This is, you'll notice that these all end in cycline. So we have declamycin, terramycin, but in their generic name we see dimeclocycline, oxytetracycline, tetracycline, doxycycline. You may be familiar with that one. It gets a lot of press, right, because of the anthrax scare. Minocycline, and tigecycline. So the tetracyclines are natural and semi-synthetic. They were obtained from the cultures of the Streptomyces. The basic tetracycline structure is this ring that has 4 fused 6-carbon rings. That's why we have tetra, because each of the tetracyclines differ on the basis of the substitution in the either 5th, 6th, or 7th position. So they are bacteriostatic. They inhibit bacterial growth. Their mechanism of action is that they then bind to the 30S ribosome subunit and impede the transfer RNA or transcriptase of the RNA at the receptor site. So they can also bind to the 50S ribosomes, but what happens whether they go to the 30S or the 50S, they ultimately end up altering the cytoplasmic membrane. And so that results in the nucleotides, the cytosolic nucleotides just leaking out, and that inhibits the microbial growth. So the tetracyclines, with the exception of both doxycycline and monocycline, the tetracyclines interact with the divalent and the trivalent cations, and they form an insoluble and a non-absorbable chelate. They bind to this calcium, the magnesium, right, and the aluminum. And so they cannot be taken at the same time as dairy products, antacid, anything that contains calcium, magnesium, zinc, or iron. Calcium, magnesium, zinc, or iron. So our antacids, milk, any iron supplements, iron preparations, bismuth subsalicylate, Pepto-Bismol, bismuth subsalicylate, kaolin, pectin, all reduces the absorption of the oral tetracyclines as well. Food, so if you have food that contains iron or dairy, right, these should not be used in children under the age of 8 or in pregnant or lactating women. because tooth coloration will occur if the drug binds to the calcium in the teeth. And I believe that I had mentioned earlier that the tetracyclines can also affect the bone growth. So we don't want to give this to children under 8 or pregnant lactating women. Our tetracyclines are wide spectrum. They're gram-negative and gram-positive. They are often very useful for empiric therapy. They're usually the first drug of choice for any rickettsial infections. They're actually well absorbed in the elderly, and they can be used, with the exception of doxycycline and minocycline. They should always go slow, start low and go slow. The demeclocycline is also used in the treatment of syndrome of inappropriate antidiuretic hormone because it inhibits the action of the antidiuretic hormone. Adverse effects, because they have this strong affinity for calcium, they'll discolor the teeth and the tooth enamel in fetuses and children or nursing infants if taken by the mother. They can also retard the fetal skeleton growth if they're taken during pregnancy. They actually cross the placenta. That chelating effect occurs. It binds with the calcium, and so we can get discoloration of the deciduous teeth, enamel hypoplasia, and inhibition of fetal skeletal growth. So we never give these to pregnant women, and we never give them to lactating women. We may get the alteration of the intestinal flora, so we get that superinfection, the overgrowth of the non-susceptible organisms. We can get, again, diarrhea, and then our C. diff, or pseudomembranous colitis. We can also see vaginal candidiasis, gastric upset, enterocolitis, macular papular rash, and other side effects. We want our patients to report any symptoms that we might see with hepatotoxicity, like persistent nausea and vomiting, dark urine, pale stools, anything like that. Another thing about the tetracyclines is that they can potentiate the effects of the oral anticoagulants, and they do this either by impairing the prothrombin activity or decreasing vitamin K production in the intestinal flora. Remember, you have to have the intestinal flora to produce the vitamin K. So we want to make sure that if we have a patient geriatric patient particularly, who's taking these, because they are well tolerated in the geriatric clientele, we want to make sure that we're monitoring their prothrombin times, or their PT-INR. So we're going to break here. We'll come back and we'll talk about nursing implications from chapter 38. See you soon.